Hello, everybody. My name is Michiel van Heijden. I'm a medical oncologist from Amsterdam in the Netherlands. And I'm joined here by Ignacio Durán, a medical oncologist from Santander in Spain, where it's clearly, even though he tried to block it with the blinds, much sunnier than here in Amsterdam. And we will be talking today about new developments in immunotherapeutic treatment of metastatic urothelial cancer. So I'll just jump right in. And I think the first topic I think we should talk about, which is basically, I would say, the most important development of the last year, which is maintenance therapy after first-line chemotherapy for metastatic urothelial cancer. So Ignacio, maybe you can explain what study was done and what the implications were for treatment.
Well, thank you, Michiel. I think that's one of the key topics that we have received in the bladder cancer therapeutic world in the recent months, and is about applying applying one of the concepts that we can use in therapeutics, which is maintenance. So once you have started a treatment, then you can either switch to a different agent, or you can continue with one of the agents that you utilize first. And the case with the study of avelumab as a maintenance strategy in bladder cancer was basically starting with 4 to 6 cycles of chemotherapy. And for those patients who had some degree of benefit, either response, partial or complete, or stable disease, those patients were randomized to either avelumab maintenance or best supportive care. And the truth is that the result was highly positive, and that was very well received. Probably, Michiel, some people may be critical about utilizing maintenance, and I heard some critical voices, and maybe it's something I'd like to share with you and also have your thoughts. And I think it's fair that people may consider, okay, why should we utilize maintenance rather than waiting for progression and then use a second-line treatment? And I think there are a number of arguments or a number of things that we need to keep in mind. And the first one is, if we understand what bladder cancer is, the truth is that despite being a very chemosensitive disease, most of the patients respond to chemotherapy and they achieve responses or stable disease. The truth is that these patients progress rapidly. And if we look at the numbers, and actually recently, some of these were presented at big conferences, there is only a minority of patients who reach the second line and are able to go through those treatments. So one of the risks of waiting for relapse and applying second line is that we're probably going to miss some patients in the way. The other thing that I think we need to keep in mind is, I think there is a biology underneath this strategy. And that biology has to do with what we call the immunogenic cell death. So we believe that utilizing chemotherapy may actually deplete immunosuppressive cell types, may increase the presentation of tumor antigens, and may probably trigger T-cell infiltration. So those would be the positive arguments towards utilizing maintenance. I understand that there's some skepticism around those patients who achieve a fantastic response with chemotherapy, the complete responders, that some people may argue they may not need treatment. And the truth is that we do not have that information completely, accurate to come to that conclusion. It's true that the sub-analysis in the avelumab maintenance study showed that the benefit in those patients seems to be a little bit less, but I don't think is enough to exclude those patients. So my take on this would be, I don't know if you agree, Michiel, is maintenance with avelumab is probably right now the newest standard of care, and it should be considered for most of our patients with metastatic disease.
Yeah, so what I'm hearing you say is that basically you would apply this to all patients who have a good response to chemotherapy, or do you think there's an ideal patient for this treatment, or maybe a group of patients where this is not an ideal treatment and you would maybe not apply this?
Well, I don't know what you do in your practice. I think in my practice, I would consider this approach for most of my patients. I mean, there may be some patients who may have some concern about toxicity, and they may have fear about, okay, what now that I got through my chemotherapy treatment, and I'm kind of getting to this point of no more toxicity, no more hospital visits, should I really get into that? Well, you need to have a discussion and look at pros and cons. I mean, the only patients where I would be more flexible perhaps would be those patients that achieved an extraordinary response and that I may think, they may not need that so rapidly. There's another population that was a bit tricky in the sub-analysis, and is those patients with particularly visceral metastases. In those patients, the benefit was a little bit less. So those are the only two circumstances where I could discuss with the patients, the possibility of not going directly into maintenance. But my take is, in most of my patients, try to proceed with avelumab maintenance if I can.
Yeah, I think that's fair, and that's pretty much how I would do it. That the benefit has been so clear that it's that I think we do need to discuss it with every patient to offer this and to give a patient this opportunity. In the end, of course, metastatic urothelial cancer is a disease that can rapidly worsen, even though it seemed that the patient had a really good response. There remain a couple of how shall I put it, nagging feelings that about this. One is that it's every 2 weeks, so a patient is very much staying a patient and doesn't really get a break from treatment. The other issue that I think we should discuss is the duration of treatment. So the study was done with basically eternal treatment, and I think it's questionable if that's useful. I would love to hear your opinion on that.
Well, that's a great point, and it's actually a point that I confront right now with other immunotherapy agents that did not set a limit in their study designs. I have patients who have been in treatment for maybe 3 or 4 years with metastatic disease and immunotherapy, and sometimes I have to sit down with them and say, okay, we do not have data that continuing, beyond this is going to help, but we also do not have data about when to stop with this particular drug. So I think is discussion that we need to have, and also balance, as you said, the time that the patient has to devote to come to the hospital is very important. I remember I read a paper not so long ago in JAMA that was one of these reflection articles about how valuable is the time of our patients and how sometimes we do not take that into consideration. So when your life expectancy is not extremely long, how much relevant is that you do not spend most of your time coming to the hospital for a benefit that can be relative. So I think that's also an important topic. I do not have an answer to tell you, what to do in terms of timing of avelumab. I think it's too early still. We do not have used the drug so much, but I'm sure it's going to be something that we'll have in our clinics more and more often.
Yeah, I think this would be a great area for collaborative trials to start looking into, trying to to start limiting the time that patients get this maintenance and see if how far you can go with this.
Let me ask you one question that is also a little bit controversial. So I'd like to hear your opinion about checkpoint inhibitors, a single agent in the first line. What's your view on that? Is something that you use often in your patients? Is something that is out of the scope now, out of the menu? What do you do?
Yeah, I think that was something that obviously for in the beginning of these treatments coming up, we were super enthusiastic and we felt that it could easily beat chemotherapy. And as a result, we have accepted first-line treatment based on phase 2 trials and in the beginning in an unselected group. And then we sort of had to change that, or actually the regulators had to change that to a PD-L1 positive group. And then in the end, from the trials that were done in a randomized fashion, the results were not so fantastic. It might be that for atezolizumab, this will still turn out to be a positive trial, but for pembrolizumab, it was not. And my take on this actually always has been that I think there is a group of patients where this could be a good idea, and it's particularly the group of patients who is not very keen on getting chemotherapy, obviously, but also has the time to try this, where the risk of rapid deterioration is very low. So what we've seen in a retrospective study that we did, I think also with you and with a lot of European partners, is that especially the patients who have more extensive disease do really poorly on first-line immunotherapy, and they never get the chance to get first-line chemotherapy. So especially in those patients, I would always advise chemotherapy, whether it's cis-eligible or cis-ineligible patients. For the cis-ineligible patients who are PD-L1 positive and who really would like to have IO, I would consider it, but in the end, it's just a handful of patients that I treat with first-line IO in this fashion. How is this with you, Ignacio?
Well, very similar approach, and actually, my government or my health authorities helped me make the decision because first-line single-agent IO is not reimbursed in the public system in Spain, so you can only receive it in the private. But it doesn't really hurt me because, like you said, I think is a very small group of patients that would potentially benefit. And I think with the data that we have right now from chemotherapy and IO maintenance, I think I try to push most of my patients for chemotherapy, either cisplatin or carboplatin. And I do not quite believe in the platinum ineligible, that kind of new concept that has been, to me, a little bit, I don't know if I should say made up, but I think when a patient is not fit for carboplatin, maybe it's not fit for anything, and maybe should not receive treatment, because ECOG performance status is one of the most consistent biomarkers that we have in the clinic. And we know patients with very poor performance status do not do very well regardless of the treatment. So going back to your point, single agent IO for a very small percentage of patients, high PD-L1 expressors and highly selected, but not many.
Yeah, no, I fully agree with you, Ignacio. Some guidelines, I think, have promoted this platinum ineligible group. I think this was created to sort of open up opportunity to start treating, to start calling a much larger group than it actually is as platinum ineligible, because in my opinion, even patients with low performance or comorbidity can often still receive carboplatin. So it's a very small group that actually cannot receive chemotherapy at all, in my opinion. And it sort of opens up possibilities to make this group much larger and treat many more patients with IO. I think we have we should move on now. We already talked a little bit about the keynote and the Vigor 130 studies, and you also mentioned, and these studies, of course, were 3-arm studies, with chemotherapy compared to IO monotherapy, compared to chemotherapy plus IO. And you mentioned earlier that you feel there is a biological synergy. So, if we find immunologic cell death by chemotherapy, this would be a great combination, one would think. But how did this end up?
Yeah, so let's put it all together. Yeah, we started with the maintenance concept. That is the one who have succeeded in first line, right? We have commented a little bit about single agent IO. And then the big question was, okay, what about combining chemo plus immunotherapy? And I think that was the big disappointment that we have witnessed in recent years. And we saw the data from in Vigor 130, so improvement in progression-free survival, marginal improvement with a high hazard ratio, not clinically meaningful, and then not benefit yet in overall survival. And then we were all very expectant about the results of the same study design, KEYNOTE-361, with pembrolizumab plus chemotherapy, and the study was completely negative. So I think the message is kind of simple as per today. Chemo plus IO simultaneously does not seem to work. And you could ask me, what's the reason why this does not work and sequencing in a maintenance strategy work? I don't know. I do not have the answer, but the evidence is what it is. So I think we should move out of our treatment schemas, the combination of chemo plus immunotherapy as first line simultaneously, and we should move to chemo induction, and those patients who benefit move to maintenance. if we agree that the patient is good to do it and the patient is happy to come to one of those programs. So I think that's one of the places for IO. But that takes me to one of the last blocks that we'd like to discuss today, Michiel, and this is a question that I throw to you. You've been quite involved, and your group has been very active in looking at combinations in the neoadjuvant setting. So is a topic that you really like, combining two different IO strategies, and anti-PD-1 or PD-L1 plus CTLA-4 inhibitors. What is your take? Because I think those combos were a little bit they did not get all the attention that they probably deserved as a first-line approach. What do you think? Because we may have data coming up not too long from now.
Yeah, this is also an exciting study that at least that because it took a while to, I guess, to enroll and to have sufficient follow-up. It is not out yet, but I hope it's coming out soon. And in this trial, which is the CheckMate 901, ipilimumab plus nivolumab is compared to standard of care chemotherapy, and then there's a sub-study with chemotherapy plus or minus nivolumab. I think, obviously I'm a bit biased, but I think anti-CTLA-4 has a role in urothelial cancer. It does add to anti-PD-1, I think. And I think in urothelial cancer, a big issue is the dosing. And that's true for other cancers as well, but it's especially, I think, true for urothelial cancer. And this has been found in the phase 2 trial in the second line setting, where it seemed that the addition of ipilimumab 1 milligram per kilogram to nivolumab didn't really alter response rate much, but the ipilimumab 3 milligram per kilogram dosing did. Another trial that I was involved in with unfortunate results was the durvalumab plus tremelimumab, and I think a major difference is that trial went ahead really early in the game. It's I think at that point we didn't really know what to expect yet from first-line immunotherapy, and we weren't expecting that some patients can deteriorate quite fast. And moreover, the dosing of tremelimumab and durvalumab is just based on not as much data as for ipilimumab is the case. So I think those are reasons that made this trial, the Danube trial, in the end fail. Although this was also, if the primary endpoint had been slightly different, this could have been a positive trial, as in the PD-L1 positive subgroup in an exploratory analysis, durvalumab was still seemed to be better than standard of care chemotherapy. But this was not the primary endpoint, so we'll never know. But I think for ipilimumab and nivolumab, this dosing issue has been investigated a bit more, and I think the dosing there is right. The only disadvantage that this study has is that it took a while to recruit. So there was much more, probably there will be much more crossover checkpoint inhibitor use, which will probably limit the effect, but we'll see. I think this is a very exciting trial. And it's not the only trial in the first line. There's another exciting combination that I think a lot of people are expecting a lot from, and that is the enfortumab vedotin with pembrolizumab trial. And that's a combination that has been tested in first line in a relatively small group of patients, I think about 50 patients, but showed really encouraging results with a response rate in this first line setting of slightly over 70%, and responses that seem to be quite durable. So I think that's going to be a very exciting trial. It's now being tested in first line in a phase 3 trial. So Ignacio, where would you put your money?
Well, let me summarize what you just said. So basically, my understanding is you still think there is a space for doublets of anti-PD-1 or PD-L1 plus CTLA-4 inhibitors, and you very well brought two examples, Durva plus Treme, and we heard some interesting data from one of the secondary endpoints of the Danube trial with exciting differences, and the second one is Nivo-Ipi, and your points were about dosing and maybe also patient selection. That's one thing. And the second thing is Ipi Pembro. And you say, where I put my money. EV Pembro seems a very exciting regime. And I mean, we're participating in the clinical trial in the randomized study. We're seeing a lot of activity, I have to say. And actually the new regime of day 1 and 8, when you combine with Pembro, is much more convenient for the patient than the design of day 1, 8, and 15, when you used EV in third line in monotherapy. So I think this regime is going to be really excited. I mean, we have to wait for the study to be completed, which I think is going to be quite fast. But to me, it's a promising regime. I'm quite excited. So I think we're coming to the end. Michelle, I'm going to have to call for a close of this interesting afternoon conversation about bladder cancer with a little bit of sun here in Santander. I presume still a little bit of sun also in the Netherlands, in Amsterdam. So it was my pleasure to be here talking to you, Michelle, about bladder cancer. I think it's a great time for our patients, and I hope 2022 is still going to be a year full of good news and new results from all those studies that are ongoing. So with this, I'd like to thank our audience, which is at the other end, for their attention. And I hope this piece of conversation has been of some use for them. Thank you all, and thank you, Michelle.
Great, thank you, Ignacio, and the audience.